Very good evening, dear friends, and welcome you all to this international webinar series, the 17th talk that we are going to be listening to. Welcome, Dr. Paul, and thank you very much, Dr. Paul, for accepting our invitation. Dear participants, a warm welcome to all of you. I would like to take this opportunity to invite our moderator for the day, Dr. Vijay Agarwal. Dr. Agarwal is not a person who needs big introduction. He is well known to all of us. Dr. Agarwal is the president of CAHO, a pediatrician by profession, and he's a crusader for quality and patient safety. With that lines of introduction, I now hand over the session to Dr. Agarwal. Over to you, sir.
Thank you, Dr. Lalu Joseph. And it is indeed a great privilege for me to be moderating this session for a very, very honored and esteemed pediatrician from a different part of the world, Dr. Paul Batalden. Ladies and gentlemen, the topic today is co-producing healthcare. And there can be no other better person than Dr. Paul Batalden to speak about this topic. Let us understand that co-producing healthcare services, actually one has to understand that you have to understand that services are very different from goods. So goods are something like concrete, you can kind of quantify, you see it, you can hold it in your hands. But as far as services are concerned, they are intangible. And therefore, there is a concept that let it be produced along with the consumer. And I think that no better, I would say, example can be there than the healthcare, where the role of patients in contributing to the success of outcomes can be there when the patients and the doctors work together to bring about better results. In fact, this talk is coming at a very opportune time, and that is the time when even at CAHO, we have launched an initiative which we are calling as a Patients for Patient Safety initiative. And one of the main issues of that is to bring patients into the whole paradigm of providing or becoming a partner in the service delivery in our system. So many times, the doctors just kind of roll out. They are not taking into consideration the environment in which this patient is living, how he is living, what is her economic issues. Many things have to be taken into consideration if I am going to weave a right kind of a prescription, if I am going to weave a right kind of a output scheme for him. So Dr. Batalden is, I would say, Dr. Paul Batalden is the Professor Emeritus of Pediatrics, Community and Family Medicine at Dartmouth Institute of Health Policy and Clinical Practice at the Jassel School of Medicine at Dartmouth, and Affiliated Professor Emeritus of Quality Improvement and Leadership at Jönköping University in Sweden. Dr. Batalden basically is a crusader, I will say, for talking about this issue of co-producing healthcare. He's hosting also a podcast series, which is the power of co-production. He has been the creator of many, I would say, healthcare improvement initiatives at IHI, at the VA National University Scholarships, at the various general competencies and accreditation council for graduate medical education, number of places. I think the best would be to listen to him regarding this very important topic of co-producing healthcare. So over to you, Dr. Paul Batalden.
Thank you very much. It's a great privilege for me to be with you today. I wish I could be meeting you in person, but that is not possible today. The question that I have been working on is this: how might we improve the value of the contribution that healthcare service makes to health? That question is what has led me to open this idea of co-producing healthcare service. And so I would like to talk about that today, just to open with you a little further what this might mean. My aim in these remarks are that I will help you recognize the difference that Dr. Agarwal opened between the logic of making a product, a healthcare product, and of making a healthcare service. I hope that I will help you recognize the importance of the lived reality of the patient person and the professional person in a service that is co-created. He referred to the roles that we play. And I think we sometimes make a mistake of calling people by their role and forget they are a person. So I have used patient person and professional person to remind me that we are both persons. Thirdly, I hope that my remarks will help shape this idea of how science informs the practice of co-produced healthcare service. And lastly, how work habits and or a work setting might limit the ability to gain insight into what's important to patient persons who are historically underserved. But I think it's always helpful to honor a poet. And so I would like to take the words of the young poet of our president's inauguration, Amanda Gorman, who said, "We are learning that though we weren't ready for this, we have been or are being readied by it." And indeed, COVID has connected us all in a pragmatic tutorial on co-production. We have learned, as we are being readied, that new and useful scientific knowledge is only partly RCT, randomized control trial based. We have learned that there is a limited social understanding of how science actually builds knowledge. We have learned that professionals alone cannot eradicate the health problem. We have learned that contextual forces like judges and politicians have become de facto public health officials, not always for the better. We love our categories, and we have seen this personal and public health schism that exists. We have learned that health inequities are everywhere we look. We have learned that we confuse role and identity, and progressively exhausted professionals are either heroes or sometimes enemies. We have learned that our information age includes misinformation and disinformation, as the leader of the National Institutes of Health, Francis Collins, observed here in the US. We have learned that we are actually kin persons, as one human to another, as we face this challenge of COVID. We have learned that change can come more rapidly than we thought it could. We have learned that when people work together, they need respect, trust, shared learning, and a sense of control. And we have learned that innovation and constructivism and reserves, or a little extra capability, are both imperative and foundational, and so much more. But I would like to turn my attention first by looking back about 100 years ago or so, when a group of surgeons asked the question, how might we recognize a good hospital? And that led to these standards by the American Board of Surgery and the Hospital Association. And with their question came the recognition of and focus on this idea of a threshold. What is the threshold for becoming a good hospital or a good healthcare service? And the initial focus was on big issues. But as time has gone on, some of those big issues have gone away, and we are now focused on peripheral or less critical issues, like did you fill out the right form? And it drives people crazy in some ways. About 40 years ago, we recognized that gains in quality and safety and value were occurring in other economic sectors at rates of change that were much better than we were able to do in healthcare. And that led to a similar focus on enterprise-wide systems in healthcare, enterprise-wide systems for best disease management. And we learned more about systems and processes and reliability and customer-supplier relationships and performance measurement. But I think about 10 or 15 years ago, the question changed from how might we use enterprise-wide systems for best disease management to something like how might we improve the value of the contribution that healthcare service makes to health. And this question helped me appreciate that there is a difference between service making and product making logic. If we think about it, professionals don't own the health of another human being. Health is owned by the person whose health it is. We have learned that as co-producing persons, we are kin to one another. And we have learned that this task requires us to integrate multiple knowledge systems. And with this different way of calling out what goes into making a healthcare service, we are invited to think about new ways of creating the architecture of value in healthcare service. And the existence of quality 2.0 doesn't mean that we get rid of 1.0, and 3.0 doesn't mean we get rid of 2.0. In fact, it's 1.0 plus 2.0 plus 3.0. The basic formula for improvement of generalizable science-informed practice times context leading to measurable improvement has given way to some combination of patient aim and generalizable science-informed practice times the context leading to measurable improvement. But in this, two words jumped out: service and value. And I was asking myself, what might I have overlooked in this idea of making a service? And my colleague at Dartmouth, John Skinner, connected me with this man who is now 90. He is now in his late 90s. And I asked him, because I got his book, The Service Economy, that he wrote in 1968. And in the opening pages of that book, he says on page 12, it takes two parties to make a service. And I said to him on the telephone, so where did you get that idea? And he said, it's obvious. And I said, you know, I'm a pediatrician. You have to be very concrete with me. And he said, well, my wife and I had 4 children. and the youngest was a boy, and he cut his hand. And my wife had a doubt in her mind about whether a stitch or a suture would help. So she called the doctor, and they had a conversation about the circumstances under which a suture would help and where to get one. So he said, you see, it took two parties to make the service. And then he added, for emphasis, you see, it's obvious. And I said, well, I think I get the point you're making. But I believe that we have taken the idea of product making, and we have used that to make a service. And then we've put all kinds of adjectives around that, like patient-centered or patient-focused or something like that. But underneath, we have used the logic of product making. Doctors make the service and sell it or give it or find some way to convey it to somebody else. So my study pushed me to understand this idea of service making, and Carl Gersony and his colleagues in the book on the Service Society were the first to use the term co-production. They had read what Victor Fuchs had written, and they said, interesting, two people making the same thing. There's co-producing going on. And then Eleanor Ostrom took that same insight with her husband and Vincent, and they talked about the co-production of public service. And for that, she won the Nobel Prize in 2009. Two people in the service marketing world, Robert Lush and Stephen Vargo, said, actually, product dominant logic had taken over our ways of thinking about making a service, and it has distorted the entire field of service marketing. And then Stephen Osborne at Edinburgh and Zoe Radner in London said that product dominant logic actually confuses the way we think about services. And so I began to open up for myself a whole literature that existed in public administration and public service that I had not been familiar with before. So I asked myself, so what is a healthcare service? And it seemed to me that as I pushed into that, there was always a relationship and some action that were two parts of a healthcare service. And these two parts were held together by knowledge and skill and habit, a shared power, a willingness to be vulnerable, and a mutual engagement in the process. But always lurking in the background was this power relationship that existed, and that sometimes tended to distort the healthcare service. It made me reflect on the ways that we had thought about a healthcare service when we worked to improve it. And what we had done in the name of improvement was to focus on the action, as if the entire relationship and circumstance and action didn't somehow come together. So my sense is that whether at the individual level or at the macro system level, what's involved here are two parties working together. And these two parties work together to create the service, whether they do that at a population level or at an individual dyadic level. And my sense is that it is never free of the dynamics and hierarchies associated with power. But I believe that underneath this, that there is ancient wisdom that is actually at work. Our kinship relation to one another lives in the ancient Hindu traditional knowledge of Vasudhaiva Kutumbakam and in Ubuntu and in other ancient sources of wisdom. But for me, the question was, what were the drivers that made co-producing healthcare service possible? And it seemed to me that there was the knowledge streams related to the patient person and to the professional person and their lived realities, the social supports that they enjoyed and the resources that they had access to. And the third stream was the knowledge of the as-is system. It's the journey to be navigated and the emotions associated with navigating that journey. It's the experience of when systems are both working and not working. And the fourth stream is what Trish Greenhalgh at Oxford refers to as science-informed practice. It's not just science of the disease or the condition, but it's science of the illness experience, and it's science of the services design that also is involved in co-producing. And what helped me think about the inclusion of the professional person was the work of John Ballot and his team in the UK in this marvelous book, Intelligent Kindness. They suggest that there are really two lenses in the glasses that we might use. One lens focuses on our kinship with one another, and the other lens focuses on the task. And together, it seems to me that these glasses allow us to begin to discover the service-making logic that is involved in braiding together these four streams of knowledge, skill, and habit. These ancient folk wisdoms give us a clear sense of how important relationships are in the helping professions. And as I've explored the daily work of co-producing healthcare service, I've used this frame to see or to look into the work that's going on. I have observed that both relationship and activity are regularly at work, even though we don't always honor relationship as we focus on activity in the name of quality. That knowledge, skill, habit, and vulnerability are all connectors to bring together relationship and activity. And that the science that informs our knowledge of disease biology is different types of science and different types of knowledge development than the science that informs our understanding of illness experience and the science that informs service design and redesign. And I have also come to appreciate that not only health, but also learning are nearly impossible to outsource. I've come to understand that service dominant logic offers us so much that we need to explore as professionals interested in trying to make better quality healthcare. I've observed that these lenses of task and kin allow us to see things that we haven't seen before. I've come to understand, as I suggested at the opening, this important recognition that there is a difference between role and person. And we would do well to figure out a way to remember both as we go forward. I've come to see that service, particularly healthcare service, is almost always a combination of things that people do for themselves, plus the support that professionals might offer. And that these systems that professionals help design and set up have to function in a way that they actually provide that support for self-care. I've also come to see that some of what we do, we think we know, because of what we've learned, even though what we've learned might now need to be unlearned. And so this challenge of both learning and unlearning is what's behind this business of the co-production of a service. But let me turn for just a short while to that other word, value, because the man in Norway who has been helpful to me in thinking about this is a man by the name of Øystein Fjellstedt. Øystein and his colleagues suggested that if we want to improve services, we need to be thinking about a different architecture of the systems than the architecture for systems of production. He said that there's really a different architecture for solving problems and making products. And the architecture of the systems for solving problems can occur at an individual level and at a population level, a shop, as he called it, and a network where we're responding at scale for a population. And that the logic or the architecture of the systems that help us solve problems is different than the logic or the architecture of making products like a value chain where we have standardized sequential processes that work. And I thought, gee, that's an interesting idea. But I didn't know how that would apply. It seemed to be like it was simply attaching one cloud in the sky to another cloud in the sky. And it didn't seem to make concrete sense until one day in Sweden, in Jönköping, which is where I have worked for the past 25 years at Rehov Hospital. There is a dialysis unit. And in that dialysis unit, what I saw, now it's my picture in the middle here. And so that's the guide to what you're seeing. But this is like looking from the sky at this dialysis unit. You walk in the door that's labeled dialysis pavilion, and that's the same blue door that's on my drawing there. And if you turn to the right as you go in, you might find a room with a single patient person in that room. And she's in that room because her dialysis has needed to be redesigned. They needed to change the way they were doing that. And if instead of turning to the right when you walk in this blue door, I turn to the left into room 2, what I might see is a whole room full of persons who are being dialyzed. And those persons are being dialyzed under the supervision of nurse persons who, with their clipboards, are checking the performance of the dialysis. But if instead of turning to the left when we walk in the blue door, we turn to the right and go all the way to the end of the hallway, what we find are 3 rooms that in fact are filled with patient persons doing their own hemodialysis. They're talking to one another, they're working on their smartphones and laptops and chit-chatting with each other. And outside of that room set is Patrick and his whiteboard. Patrick is a former patient person, and now Patrick orients new people and keeps track of the need for people's use of the machines and the spaces and the equipment. And over in the far corner is Nils Johan, the nephrologist, whose responsibility is for the work as a system. And I suddenly realized that number 1 was an example of a value shop, an individual dyadic kind of thing. And this network, the whole red box, was for working with a population at scale for dialysis services. And within this, at a granular level, are things that resemble making a product, like putting a needle into a vein or hooking that patient person up to a machine. So I began to see that what Oyston and his colleagues were talking about was actually possible to use in healthcare. But I would need to think about this more. And I began, since I saw this, to see other examples where this service architecture was at work in learning health systems and learning health networks, as well as individual kinds of settings. So I've come to understand that there are some implications of this healthcare service co-producing, where health is not really outsourceable, even to prepared professionals, where professional preparation and practice, education, design, system, leadership development, integrative thinking are all at work. And that clinical practice knowledge, just like in genomics, can occur both in large groups and in small N-based learning systems. Safety might involve the patient and family roles for safer healthcare services, because it may just be that Charles Vincent and Renee Amalberti are right when they said that healthcare service safety is not a binary phenomenon. It's not that healthcare services are either safe or unsafe. We need to make them safer with an ER at the end of the word. And we've seen that registries that started as disease registers are now migrating to learning networks and teams of teams, so that new approaches to value creation are really available. My sense is that as I've been sort of stepping back and reflecting, that these questions that are underneath my thinking might also be considered by you. So how is service making different from product making? How are relationships important to health? And is this new knowledge? How are the scientific methods similar or different for building knowledge of diseases or conditions, or knowledge of the experience of being ill or having a condition, or the knowledge of the design and assessment of a service? What are the streams of knowledge, skill, and habit that help co-produce a healthcare service? And when have you experienced the co-production of a healthcare service? So my sense is it would be smart if we took just a few minutes to step back and allow you to jot down your own answers or thoughts or questions about this. So let me pause for about 4 or 5 minutes and let you try to answer one of these questions, and jot your questions down in the Q&A function of Zoom, and we'll then pursue them.
Dr. Paul Batalden has very beautifully explained this entire concept. And I think one of the most important points that he made was to make a difference between when we see a patient and we are there, let us see each other as persons.
Yeah.
And I think that change of attitude will bring a change in our entire process of thinking. Although I think what he has been able to do is that probably in our part of the world, Dr. Batalden, we'd like to know that there may be a huge number of patients who may still be happier with the product.
Oh, yes. Oh, yes. Oh, yes. Oh, yes. You're right. It's not just your part of the world. It's everywhere. You see, this is not a change that will happen next Thursday.
Yes.
This is a change that will take years to do, because we have taught people this other way.
Yes. And there is no doubt about it that at least we need to make a beginning in adopting this concept and getting on very seriously to this concept of co-producing along with the patients as persons.
Mhm.
So how is service making different from product making, Dr. Batalden?
Well, it's a very interesting question, actually, once I started to fool with it, because I realized that I love to make products. I mean, I love to do that. I've thought about that way. And when we adopted what Toyota did and what Toyota was doing in their workplace and what other kinds of product making settings were doing, and we could see that process A happened before process B, which happened before process C, and they had to occur in that order if we were going to make it all. The logic of making a product is so compelling. And I realized that as I tried to put that thinking to work in healthcare, that I would come up around these difficult problems where it didn't always work in a linear way. Sometimes we started out to go from A to B, but then C happened before we finished B. And then sometimes people entered at B, not A. And so I realized that my linear frame of thinking about this was not the way it actually worked. And so I said, well, you just have to live with it. I mean, we're going to do this linear thing because it's easy to understand. It'll help us clarify what the situation was. And then I started to have conversations with patient persons about these steps, what they called B, step B, was not the same thing I called it. And so professional terms for thinking about these things were not the same as patient person terms for these things. And I realized that a flow diagram of step A, step B, step C actually had contributions along the way that were more than one party making the contributions. I began to realize that there was, in fact, at step A, there was a contribution that patient persons made and professional persons made, but that we weren't in the habit as professionals of acknowledging that as we were going forward. And so my sense was, gosh, there's a lot to this service making, different than what I was in the habit of creating as a product design system. And so then this idea of trying to wear a pair of glasses that had one lens focused on kin and all the differences that exist amongst those people that we simply sometimes call the patient actually would have different resources, would have different questions, would have different sources of support that exist. And I thought, how is this possible to actually develop any knowledge that's going to be useful? And I realized that's the same challenge we face in genomics today. We started out thinking it is the gene. Well, cystic fibrosis today, we realize that there are subgenomic clusters and that those are influenced and express themselves in different ways. And so this complexity, we want to impose simplifying ideas on the work that we do in order to make it understandable. But sometimes those efforts hide the reality that we in fact must address. So I've begun to understand that this service-making opportunity is an opportunity for inquiry and for new methods and new approaches to the improvement of healthcare service, and offer a lot of possibility.
You feel that, see, even in the past, even when we were into the so-called product making, history taking was a very important part of the product making.
Yeah.
Is it that history taking, which was actually speaking to involve the patient, and that art was kind of dying away, and that is why there was a need now to make this change?
Well, I think we have really focused on putting the Band-Aid on, just like that picture showed. And we have forgotten. We've made assumptions that relationship would take care of itself. And it seems to me the ancient wisdom has been calling at us for doing that for years. And it doesn't matter the culture.
How are relationships important to health? Is this new knowledge?
I don't think it's new, but I think we've forgotten it. That's what's new.
Yeah.
We've made assumptions about it.
Hmm.
So the idea of relationship is not new. Relationship is an old priority.
What streams of knowledge, skill, habit help co-produce a healthcare service?
Well, my sense is that there are at least these four. Maybe there are many more. But in my thinking about it, if we think about the stream of knowledge and skill that are involved in understanding the lived reality of the person we sometimes call a patient, or the lived reality of the person we sometimes call a professional, we begin to see so much more, so many possibilities. Such a small part of a patient person's life is spent in the presence of a professional person. And we have made the assumption that all the rest of that life somehow takes care of itself and is unrelated to better health. I don't think so. I think actually that the whole person brings an opportunity for better health that we have the opportunity to recognize and pay attention to.
You experience the co-production of a healthcare service.
So I have asked groups of people for 10 years this question. And I've asked them when they're in a group of 5 or 10 people, and we are gathered. I said, would you just take a piece of paper out and write about a time when healthcare service worked well? Just write it on the piece of paper. Don't talk to one another. Just write down what happened when healthcare service worked well. And then after maybe 10 minutes or so, I ask them to turn to their neighbor and to share their stories, what they have written. And what people have written about is a time when the healthcare service was co-produced. This is not magic. This is not something that comes from outer space. This is something that occurs periodically and from time to time. And then if you start to ask the question, so why don't we do that all the time? Then you open the conversation about the kinds of change that we must begin to conceptualize.
There is a question that, can you explain what quality 4.0 in healthcare and linking with co-producing better healthcare services?
I don't know. I'm still struggling with 3.0. I'm still struggling to try to understand what co-production of a healthcare service involves. I'm sure there probably will be a 4.0, but I'm not sure I will live to see it. My sense is that if people are curious about what we've talked about, there's much more that they might take a look at. There's articles that have been written. There's a podcast series that you introduced at the opening. And these podcasts are now available on Apple or Spotify or Amazon or Google, or they're at Jönköping at ICON, the International Co-Production of Health Network. And you can get all of these podcasts and the backup materials and so on that website. The articles are here. There was a recent supplement to the ISQua journal last November that was entirely devoted to co-production. So there's lots of places where people can find this out. There's even a textbook now that's been written about co-production by this Danish doctor, Morten Soderman, because he says our bodies and most of the diseases that we have are in common, but it's the life story, the social events, the resources, the trauma, the actions, the help you receive, and the social consequences that determine whether we get sick. how we get sick, how we live with illness, and how long we live with it. And this book takes many examples of how to co-create sustainable solutions with patients, no matter how complex their problems are. This is a free English version of the textbook that is on the bottom of this slide. So what you don't know will hurt the patient is the name of the book. And it's been translated now from Danish into English. And this is the text, the web address for that text, and you can get that. But I'd like to close my remarks, and I realize that our time is limited today, with the words of the same poet that I began the talk with, Amanda Gorman, such a talented young woman. She says, "So let us not return to what was normal, but reach toward what is next."
Do you see certain logistic or practical problems at the ground root, especially when you are trying to make healthcare affordable and accessible? Do you feel that this approach, will it be more time consuming for a clinician?
Well, I think that there are, of course, ways to do this so that it becomes more time consuming, or ways to do this so that it becomes less time consuming. One gastroenterologist decided that he asked the patients he had been seeing with inflammatory bowel disease the same questions every time they came to see him. And so he simply gave the patients the questions, and he asked them to answer them ahead of the time and to enter them in a text that would send back to him. But he added one additional question: what's most important to you that we discuss? And what he found was that he could take what this one woman had sent him by way of an earlier answer and simply put that directly into the electronic record. So he saved the time that he would normally spend asking those questions of her, and focused instead on the last of her comments, which was, "I'm considering marrying a man who also has inflammatory bowel disease. What are the implications for any children that we might have?" So he could devote his entire session to what mattered the most to the patient. Well, he felt good about that, and she felt good about that. So it actually took less time.
Oh, just let me put it, the last question is from Sheikh Pachemia. The present era insurance companies converting the providing services as products.
Yeah. Oh, they love it. They love it. And my sense is that if we relied on financing mechanisms to be the engine of innovation in healthcare, we ought to simply give it up.
So I think, sir, it was a wonderful food for thought, and definitely something that what I loved most was to consider us as persons. I think it gets rid of your ego, it gets rid of the kind of a power that you build in your mind. And I think that's the game changer. That's the kind of a situation which will lead us to be better human beings, better doctors, and I think better outcomes. It was indeed a pleasure to listen to you and listen right from the crusader of co-producing health. And we would love that we be associated with you for many, many more activities of CAHO. The CAHO is a very unique experiment and experience. We would like to share more about it in due course, and we would want you to be associated with us, sir. Thank you so much.
Thank you for the privilege.
Over to Lalu Joseph.
Thank you so much. That was indeed wonderful. I mean, it's been a great session, I must say. You know, I always wonder, what is this co-production? Though we all know what it is, but it's great to listen to the overall concept of this co-production in healthcare. And I think probably the traditional medicine and people those days practiced it better. And with time, we have lost it somewhere, and it's time to regain that. And Hippocrates has written very clearly, he says, the physician must not only be prepared to do what is right, but also make the patient cooperate. So that's probably what is co-production.
Yeah.
And I have got excellent experience, I must say. My grandfather was a doctor practicing down south. And I always say this in my sessions, that I remember getting the best of the produce from the market, whether it is the first egg or the first banana that grew in the neighborhood, coming to our house. And they always were, part and parcel of the healthcare delivery system and also the families in that locality. So maybe it's time to get involved with our patients, and it's a great learning. Thank you very much for that, Dr. Paul. And I would like to express our gratitude by presenting to you a virtual certificate. And I would request Dr. Vijay Agarwal to do the honors.
Really our honor to present this certificate to you, sir. Dr. Paul Batalden, for your contribution as a speaker today for this very important international webinar series. Thank you so much, sir.
Thank you very much for this. I appreciate your recognition. It's a simple idea. It's just that it's not so easy to carry forward.
Absolutely. Yeah. So thank you, dear participants, for joining us.